Hey guys, welcome to Lesson 9 of the Medical Care Organizations course. Today, or in this lesson, we are going to be looking at managed care. Okay, so we're going to go ahead and figure out what that is and look at some different aspects of managed care, how that affected the healthcare system, and how it's doing now, what we have, what's most common about it, what should we be most familiar with, and things like that. Okay, so managed care has become very, very common. It's very commonplace in healthcare now, in our U.S. healthcare system. It became very successful over the years, and most of managed care's success started in like the late 80s, okay, and 90s, and this is because of the failures of the fee-for-service system. Okay, remember back, the fee-for-service system, that was like basically when let's say a physician takes care of a patient, then the physician needs to bill the insurance company, okay, for those services. And what the physician would do is just give like an itemized bill, like, here you go, and here's like the bill, and it'll be like, I did this, and it cost this much, and this much. Here's your total. And then the insurance company would be like, okay, here's the money for the individual things that you did that are written on this invoice. The fee-for-service system did not have any kind of like regulation. They didn't, check any kind of legitimacy of the diagnoses. They didn't really they didn't force the doctor to rely on like the referral system and the gatekeeping system. So the physician was never required to like approve of a patient going to see a specialist or referring a patient to go see a specialist. A physician never really had to do that. Many patients at this time could actually go straight to a specialist, and then the specialist will do all their work, and then they too can bill the insurance company and just give them the itemized bill. So it's just fee for service. These are the different things I did, and this is what it costs. Give me the money. Okay, so in this system, it was very easy for physicians to abuse or really exploit the patient. Okay, and they would exploit the patient, maybe give unnecessary tests, or maybe even bill for things that they didn't really do, or they could bill high costs for certain things that do not cost much at all, or just, of course, like I said, do very unnecessary things. All right, and since there's no regulation, there's no one checking that, then the insurance company would be like, oh, okay, that's what you did, here's your money. Okay, and then so they would get the money, and basically there was a lot of waste and exploitation of the patient. Okay, those uncontrolled costs are that's one reason why we have really high healthcare expenditures in this country. Okay, so and that whole exploitation and waste and everything that was derived from fee-for-service, okay, that caused what we call moral hazard. Also, fee-for-service allows for provider-induced demand. Like in this situation, the provider, the physician, of course, can induce the demand. The physician can tell the patient, look, this is what's wrong with you, this is what you need, this is the treatment, and all that. So they can induce the demand for their services, and then they could charge whatever they want, and then they can exploit the patient in that way. So both of those So fee-for-service allows for moral hazard and for provider-induced demand. Both of these are definitely are related, and they also drive up expenditures, healthcare expenditures in this country, and cause a lot of waste and exploitation. Okay, so in the earlier years of managed care, there was a lot of backlash, and that's because managed care, they took what fee-for-service was doing, and they're like, well, great, we're gonna literally they found the flaws in fee-for-service, and they decided, great, we're gonna be the solution to fee-for-service, to the problems of fee-for-service. And they figured the solution is cost control. Okay, we got to get really strict about cost control. Okay, so they put really tight controls, okay, on everything that they were doing, on all their rules, all their policies with their patients, everything. They put extremely tight controls. And in the beginning, around like the 90s and whatnot, they received a lot of backlash, okay, because people were sick of how strict they were. All right. And in response to all this backlash, the government had to step in at a certain point, and they had to say, okay, managed care, you're too much. Okay, you're doing too much. You're not helping anymore. You're hurting. Okay, when you do too much like that. So they actually we're gonna see later on that they actually put some regulations into managed care. So the government did. So managed care was not able to be as strict, as ridiculous as they were, and for that reason, they were not able to evolve as they originally had intended. A managed care today probably would have been different. Okay, whether that's a good thing or a bad thing, we don't know. I don't know, but they did not necessarily get to become what they were supposed to become because of that. Okay. All right. So what is managed care? Managed care is really more of a concept. Okay, a managed care organization upholds this concept, okay, and they base all their policies and like the whole system based on the managed care concept. But managed care itself is just a concept, okay? So it's an organized approach to deliver comprehensive services to enroll members, okay? Managed care, or the concept of managed care, utilizes the core features, or well, remember back when it was, I think, Chapter 2, when we looked at the quad function model, okay, of a healthcare system. Like, these are the 4 basic parts of a healthcare system. Managed care incorporates all 4 of those parts into their healthcare system. So managed care, the concept is actually like an approach or like a creation of like a system, okay, its own system of how healthcare should be delivered. Okay, so managed care it integrated the financing component, insurance, delivery, and payment, okay, into the managed care concept, and then managed care organizations adopt that concept, and then they create their whole system. Okay, so the integration of the quad functions. Okay, how are they using these different functions? First of all, financing. Remember how we said that financing basically comes from everyone, because everyone's dumping money into the healthcare system in some form or another, whether it's through taxes or your healthcare, your insurance premiums, or charity, or whatever you're doing, you're putting money into the healthcare system. Well, financing in managed care, a little bit different, but this is also a way that money gets dumped into this healthcare system. So financing is going to come from premiums, right? From premiums that the employers pay, okay? So a managed care organization will negotiate with the employers, okay? Because the employers are the ones that provide the insurance for their employees, right? Okay, so in order for their employees to become beneficiaries of that particular managed care organization, the managed care organization negotiates with the employers, and they come up with the premium amount that the employers are going to pay to the managed care organization. Okay, so they negotiate. Premiums are still being paid, but in a managed care organization, it's usually the employers that are paying the premiums. Okay, it's not necessarily everyone, and like taxes and all that. Okay, so next is insurance. All right, so insurance. The managed care organization, remember how the purpose of an insurance is to protect against risk, right? Well, the managed care organization is going to assume risk of the individuals, of all the beneficiaries. So they assume insurance risk. They're not an insurance company really per se. They're more of a system, but they act as an insurance company for the individual patient. So they are going to assume the patient's risk or the beneficiary's risk. Okay. Then we got delivery. Okay, delivery, this is the part where the physician, provides the service. Okay, so in this case, where are the physicians coming from and how are they providing the service and whatnot? Well, in a managed care organization, typically the service is going to come from physicians that they either have contracts with. Okay, the managed care organization will contract with physicians. Okay, so those physicians within their that they contract with are going to be the physicians that are in their network. And usually, most managed care organizations will allow patients to only see the physicians that are within the network. Okay, the ones that they've already created contracts with. Okay, so it's not always contracting. Many times, managed care organizations also hire physicians as well. So they might hire physicians, and then those are going to be the physicians that take care of the patients. Okay, those ones that they hire and pay on salary. Okay, so now we look at payment. Payment is basically, in a managed care system, it's like risk sharing. Okay, because the managed care organization doesn't necessarily assume full risk of the beneficiaries, of the patients that are beneficiaries of the managed care organization. Okay, the managed care organization actually shares a lot of the risk with the physicians and the facilities that they have contracts with. Okay, so the managed care organization, let's say they already negotiated contracts with the physician or they hired the physician. Okay, in those cases, they're not just sending. It's not like the patient is going to see that a physician who is completely independent, no contracts with anybody, and they just accept insurance. It's like a fee-for-service system. And in that situation, the patient or the physician just gets paid based on just that service. And anytime that patient requires healthcare service from that physician, their insurance company will just pay that amount. Okay. Now, in a managed care organization situation, it's not really like that. When the patient receives, if the managed care organization had contracts with a physician, then anytime those patients go to see that physician, then those physicians are going to only care for that patient. They are going to care for that patient as many times as they need to, but they're not going to bill the managed care organization every time they see that particular patient, because that's not how it's going to work. What's going to happen is the managed care organization is going to pay that physician just like a one monthly fee, you know, for every patient that they're taking care of that are enrolled with them. And it doesn't matter. In that case, it doesn't really matter at all how many times those patients go to get, you know, treatments from that physician. That physician's only going to receive the same flat fee, amount of money from the managed care organization. Okay, it's always going to be the exact same amount. Okay, so that physician is really sharing that risk with the patients, with the managed care organization, because the managed care organization isn't going to pay for everything for those patients. They're just going to basically give them like a membership fee, a flat fee every single month. It's like, you take care of the patients however many times you got to take care of that patient that month, I don't care, but you're going to get the same amount of money every single month from me. Okay, so in that way, they share the risk. I hope you understand this. They're sharing the risk because the managed care organization does not have to pay a large sum of money every time that physician has to provide services. Okay, so that physician and we'll get it more into how this is structured a little bit later. So for the most part, that's how it is. And same thing if you're using like a salary. If you're hiring that physician on a salary basis, you're paying them that same amount of money every single month, right? And then regardless of how many patients that physician saw, or how many times that physician saw that one particular patient who keeps coming back, that physician is still getting paid salary. It doesn't even matter how many resources this physician uses, they're still getting the same amount of money. They're not getting less, they're not getting more. Okay, so in that way, they share that risk with the managed care organization, or the managed care organization shares that risk of, you know, the patients with the physicians. Okay, because if it were the other way around, or, you know, if they didn't share the risk, then the managed care organization would be fully liable and have to pay for the whole treatment every time a patient needed some sort of treatment. Okay, I hope that makes sense, but let's move on. Okay, so besides cost control, because I know I've said this before, cost control is managed care's favorite thing in the whole world. Okay, they love cost control. They love controlling those costs. But besides cost control, they do have a few other things that they like to work on. Okay, but I do want to let you know that a lot of these objectives, or a lot of these goals that they have, are actually related to cost control. So I don't know what they're talking about when they say objectives besides cost control. It's mostly all cost control. Okay, so anyways, let's look at this. So first we have accountability for quality and cost. Okay, then measurement of health outcomes. Okay, so they want to measure good measurement of health outcomes and quality. That is actually a big thing about managed care organizations. They do care a lot about quality. They want to be able to make everything very efficient and cost, you know, effective. But at the same time, it's always about increasing the quality, always about providing the best quality for the lowest price. Okay. Also, health promotion and disease prevention. And this is actually tied into cost control, okay, because we all know, or we should know by now, that when we focus more on prevention and primary care, okay, so that's basically all about health promotion, disease prevention. Let's make sure that we don't even have to go there and have a lot of, have all these morbidities and have a lot of things wrong with us. Let's try not to even develop a chronic illness, and let's just try to promote health and stay away from things like that. That is always going to save money, okay? Just not even going there. Prevention is the best way to stay healthy, and it's the cheapest way, okay? So cost control, of course, of all things, managed care would definitely be focused on health promotion, disease prevention. Let's not even go there, right? So then we have management of resource consumption, which is definitely related to cost control. This is restricting utilization, okay? So of course it's related to cost control because the more resources we consume and use, the more we're spending, okay? So we do like to manage that, restrict it, let's not allow waste, okay? And then consumer education, which is definitely tied into cost control, and of course health promotion, which is also tied to cost control, because the more that the patients know about their health and they're able to take care of themselves, the less money they're going to spend on healthcare in the future. Also, continuing quality improvement, which is another huge thing, but at the same time, providing quality care is definitely related to cost control, because if you provide great quality care, you know, people will have faster recovery times, less invasive procedures, you know, just better, less infections, less medical error, things like that. And that's obviously, of course, going to control the costs. Okay. So the growth of managed care. Managed care grew out of two main factors. Okay, first of all, the flaws in fee-for-service, which we have actually touched on a few slides ago, so we won't get too much into this, but also the weakened position of weakened economic position of providers. And I know we've talked a little bit about this in like the previous lesson, or no, I think it was lesson 7, but let's go ahead and look at this again. Okay, so what was going on in the 80s was many of the providers were in a bad situation, because what happened in the 80s? This is all related to the same thing. Oh wait, anyone know? Yes, okay. It was the shift, the reimbursement shift, the Medicare reimbursement shift when we went from cost plus to prospective repayment system. Okay, when that happened, of course, the hospitals that, you know, were surviving, they switched their focus to outpatient, to growing their outpatient. Okay, they invested a lot in outpatient units and procedures and more outpatient treatments and things like that, right? So when they did that, they suddenly started competing with like all the private practices, all the solo practices, all of the group practices, you know, all of them. Now they were competing with them. And who's gonna win? I mean, be real, who's going to win in that situation? Of course, the hospitals. They have more capital, okay, so they can get all the best, newest equipment. They can pay for all the latest advances and, you know, whatever treatment that will help make their outpatient stuff more efficient and cool and attractive to all the patients. And so so they were getting more business, and the providers were suffering. Okay, also during this time was the private health insurance companies decided that they were going to raise their premiums, okay, because suddenly the hospitals started going, we're not going to make much money off of the Medicare patients. Let's go after a lot of the private insurance patients. So they try to focus on getting business from them a little bit more as well. And when that happened, now the private health insurance people are like, wow, looks like a lot of our patients are, you know, suddenly needing health care. Okay, so they've raised their premiums. Now at this point, we have employers that are mad, okay, that they raised the premiums. And we also have providers, physicians, group practices, solo practices who are like, oh shoot, the hospitals are competing with us. We have no patients. Like, we're not able to make money. And then, you had the hospitals who are like, we have to find ways for us to, push our services to outpatient, and we have to just, they're looking for ways to stay afloat now that Medicare decided to change the reimbursement system. Okay, so managed care was like, wow, what an opportunity. So managed care hit the economy on a couple of different angles. So let's talk about the providers. They saw that the providers were weakened economically. They weren't able to get as many patients, okay? And then they also saw that the employers were mad, okay? They don't want to pay these really high premiums and things like that for their patients, and they didn't believe that they were actually getting quality care for as much money as they were paying. So what managed care did was they went to the employers. They were like, great, give me, let's negotiate. And they advertise, or they really push the whole cost control thing, and we're great quality, but we also reduce costs, and we're very efficient and effective and all that. So they really made the employers go, yeah, you're definitely what we need. So the employers took them on. The employers got contracts with them. The employees started paying their premiums and gave them all their employees as the patients, the beneficiaries. So managed care goes to all these providers, these the group practices, the solo practices and whatnot. Managed care organizations go to them and they're like, look, we know you're struggling for patients and we got all the patients. All right, so we are willing to give you patients, okay, but you got to sign a contract with us. Okay, so a lot of these providers did not have much of a choice. They settled and they went with managed care. Okay, and managed care took advantage. They had all the leverage. So managed care created contracts with these providers and basically used like a capitation system with them. They paid them based on a capitation system. And what that is the managed care gave basically a flat fee for each patient that these providers were enrolling. Okay, so a flat fee per patient. So one flat fee per patient per month. Okay, so they started paying, if that provider took on like 5 other patients, then they would pay them for those 5 patients every single month, and you just get one flat fee. So then these providers are required to follow managed care's rules and their standards of quality when they're caring for their patients, and also they have to, provide care for their patients. The thing about the capitation system is the providers have to take care of them regardless of regardless of how many times that patient needs care. So a patient might never go see a physician, go see this doctor, and the managed care organization will still pay them that fee for that patient every month. And then there may be some patients, okay, that are assigned to this provider that need a lot of care. They might have all these chronic illnesses that the provider has to help, care for. And so they might be seeing that patient every 2 weeks or, often. And the thing is, they're going to still just get paid that flat fee per patient for that patient every single month. So regardless of how many times they see that patient, still that same amount of money. So in a way, it's good, but it's also not good, Anyway, we already talked about the flaws in fee-for-service, so let's move forward. Okay, employers' response to rise in premiums. We already touched on this actually. Okay, so basically, we had many, premiums started to rise in like the late 80s, right? And it was during this time, and that's what was happening. So it made a lot of employers leave their traditional indemnity plans. Indemnity insurance is like that. It's just your standard, like traditional fee-for-service type of an insurance plan. Okay, that's what that is. So it made a lot of employers go, look, I am not paying this much money, because the premiums rose to double digits around this time. And you know, that was insane for that time. Okay, not so much anymore. We probably would love to go back to that and only pay those premiums. But you know, back then it was tough. It was ridiculous. So they left. All right, and then they were seeking another option, and then here comes managed care, and they're like, hey, we do cost control and we're cheaper, but we hold on to quality and all that. So then the employers were like, you're the ones we want, let's negotiate. And then they created contracts and figured out the premiums for that. So providers' weakened position. We really just touched on all of this, so I'm gonna allow you to process that story that we just talked about. Anyway, so the efficiencies in managed care. So why was managed care good? How are they like efficient? And on top of everything, well, they eliminated insurance and all these payer intermediaries. They started a risk-sharing thing with providers, which I already kind of touched on what that was. Okay, so basically the managed care organization, it was not fully financially responsible for each treatment. Okay, they created a situation in which you know, they would be somewhat responsible, okay, but not entirely responsible for. It's not like how insurance is, where it's like, here's a pool of money, everyone contributes to that pool of money, and then whenever something happens to someone, then the insurance completely pays for it, or however that is. Managed care, they created a system where they're like, well, we'll either hire the physicians on salary, okay, and so they're going to get their usual salary, but they have to, you know, pay, or they have to fully take care of the patients. Also, they did contracts, and that's kind of in a way kind of like salary, but they basically, when they did those contracts, a lot of that was just based on capitation. And remember, we said capitation was this flat fee per member, you know, per patient per month. Okay, so just, it's like, no matter what you do for the patient, we're only giving you this much money, and you still have to abide by our rules and everything. But at the same time, these physicians are not going to see every single patient every day, or, you know, most of the time you're not going to see every single patient every month. So you know, many times it's kind of good for them, and they're just sort of collecting checks, okay? Because a lot of the patients they're not necessarily seeing every day or even very often. They're probably only seeing a fraction of their patients quite often. So that kind of makes up for it. So anyways, there's this whole risk sharing with the providers. So neither the provider nor the managed care organization is fully responsible financially for the patient. They're sharing it, okay? All right. So managed care also monitors the delivery of services for appropriateness. So they do have their standards of quality, they have their rules, their policies, their utilization rules, and everything like that. And managed care was very strict in the beginning with all of this. So hence the whole cost control thing. Okay, so they really like to monitor the services and what they're doing for the patients, and making sure that everything is necessary and that no waste is happening. Also, they deliver care in cost-efficient settings. For example, they use outpatient, or they like to focus on outpatient instead of inpatient stuff. So just like the hospitals, managed care does the exact same thing, because they know, hey, outpatient is so much more less costly. and it's more cost efficient, and it also might be, decent quality, or it might be better quality. Certainly there are less risks of, other things happening, like infections and things like that you would normally, that might be present or that might be more of a risk if you stayed as an inpatient in a hospital. So, much more cost efficient as outpatient, and managed care realize that. So that's another huge thing that they do. So some inefficiencies, some things that are doing totally wrong or just messed up. First of all, the complexity for providers of having to deal with numerous plans. So this is just sort of adding to all the different plans that the physicians and whatnot have to deal with. Okay, it sucks. They already have to outsource their billing, so they have to hire someone else to do another company to handle their billing and their coding. Okay, for all the different insurance companies that they have to deal with. And then many times providers have to know what that patient's insurance company is even going to pay for, because the provider doesn't want to just do that service or or that treatment, or even promise something to the patient, and then that patient isn't even gonna, it's not even gonna be paid for by the insurance company. So, and providers have to actually know what insurance companies are actually going to pay for before they even really take care of a patient. And so this is just adding to the problem, of course. Anyway, so then there's laboratory, and some other services have been carved out, and that creates a lot of inefficiencies for the patients and for the providers. And this is what it was. It was like this back then in the more beginning times of managed care, when it first kind of came out, because now many managed care organizations actually don't have much carved out, at all. They might have psychology carved out, or other alternative therapies and treatments, but labs are definitely something that they have, okay, that they pay for. They're part of it. They usually contract with different labs and whatnot. So also another huge thing that is still a problem are the lengthy appeals for denied services. Now, managed care is very strict, and I've said this so many times before. Managed care is very, very strict. They focus on cost control. So they regulate everything. They regulate utilization. So when you submit for approval for a certain treatment, or to see a specialist, to get a referral approved or something, and they deny it, that sucks. And normally what happens is you have to appeal that decision if you believe that your patient still needs, that service or that treatment, whatever that is. And so you submit an appeal. But the thing is, the whole system actually takes forever. And what ends up happening is that patient, whatever their illness is, whatever's going on with them, it might actually be time sensitive, and they could be getting worse. Okay, so they could be getting worse, and then the treatment that they're going to require later on is going to be even more intense and more expensive. So that is a major inefficiency in managed care that I guess they didn't really think about. But anyway, so a need for cost control. 10% of patients with chronic or complex conditions account for 70% of all of the healthcare spending. Okay, that's a lot. And hospital services cost about 50% of all of the medical care. All of it. Okay, we were spending so much money on medical care, it's not even funny. Well, I do recognize that a lot of it is necessary, but a lot of it is also not necessary. A lot of it may be wasteful, or we're just doing inefficient things. All right, so there are a lot of inefficiencies happening in our healthcare system, and so managed care came out and was like, we're gonna fix all that. I don't know if they fixed all of that, but that's their deal. So utilization management does require expert evaluation of what services are needed, determination of how to provide services inexpensively without compromising quality, okay? And then you need to review the process of the care. So they've actually created a utilization review system that takes on all of that, okay? So let's learn more about that. So, managed care's cost control methods. All right, let's get into what these are. So first of all, they have this choice restriction thing. And I think since managed care is very common, I'm assuming that most of us have a managed care or work with a managed care company. Not work with, but like you're a beneficiary, okay? So if you are, you probably understand the difference between closed panel and open access. A closed panel in a managed care organization are those managed care organizations that do not allow you to see physicians that are outside of your network. Okay, so there might be a circle of physicians that that they've already contracted with, or maybe they hired. So this is all on salary. And then there are physicians that are outside of the network, right? But the thing is, or if it's a closed panel, you are only allowed to see a physician that is within this network. You're not allowed to see a physician outside of the network. Okay. And they just don't pay for it. Okay. And then if you have an open access with the managed care organization, typically there are only a few types of managed care organizations that do allow open access, and we'll get into which ones, or the main one that everyone knows about in a couple slides. But so open access is where they have their network of physicians that they've contracted with, that they want to work with. They prefer you to use them, but you are allowed to go outside if you choose to go outside. It's usually, if you go outside, you're going to pay higher out-of-pocket costs, but they allow you that option if you choose to. Okay, so gatekeeping, the gatekeeping system. Most managed care organizations will have a gatekeeping system. Not all do though, but most. Anyway, so what this is you have your primary care physician, and that primary care physician is your portal of entry into the healthcare system. So it's kind of like they are a gatekeeper, okay? And you cannot pass through and go see specialists or do other things without your primary care physician's referral. And that is the gatekeeping system. Okay? Then we have case management and we have disease management. Okay, so if you have several diseases, okay, you may need a better coordination of care for your complex and potentially costly cases, right? So what managed care does is they go, well, normally your primary care physician is going to take care of that, and they're supposed to coordinate your care for your diseases. However, if you have many complex cases, they're probably going to assign you to a case manager, and they are going to be the ones that coordinate your care. Okay, so they will be the ones that coordinate, especially your secondary and tertiary care services and things like that. Okay, because they want to make sure that they are able to save money. Okay, and that you are actually you're doing what you're supposed to do as well. Okay. Next we have disease management. So this is a system that they have come up with that focuses on managing your disease. So if you have disease, especially if you have chronic diseases, chronic problems, they will try to come up with a strategy for your chronic illness. Okay, they're going to focus on your education of your condition. Okay, self-management training, monitoring your disease and your progress and things like that. They'll do a lot of follow-up to make sure that you are complying with your checkups and with whatever you're supposed to do, and with any kind of self-care, like instructions that they have given you. That is all going to be done under disease management. Okay, so the goal under disease management is to prevent further complications of your disease. Okay, so then we have pharmaceutical management. So there are 3 different levels or 3 different strategies of pharmaceutical management, or getting pharmaceutical drugs in managed care. So 3 different levels. The main thing that we want to focus on are the drug formularies. Okay, so this is basically like the first stage. This is pretty much most managed care organizations will have already like a list of drugs that are approved and ready to go for physicians to prescribe to their patients, and when you go pick it up from your pharmacy, you're going to have no issues. Okay, there's no need for approval or anything like that. But when you get to the higher levels of the main strategies of pharmaceutical management and managed care, then you are going to have to wait for your approvals, and there may be cost sharing, okay, that is involved. So you may have to pay some money to get those drugs, and you may also have to wait for the managed care organization to approve for you to have that medication. Okay, so next let's look at utilization review. This is actually important. This is the big deal, so let's pay close attention. All right, so utilization reviews, basically these are where you have somebody reviewing every single case. Okay, and every time that they're going to review the case to determine appropriateness of services, they're going to ensure that everything done was cost efficient, that there's no waste, and everything done was according to like our standards of care. So you performed quality care for the patient. And this is also to make sure that we are able to plan your further care, your follow-up care, and things like that appropriately. All right, so there are 3 different types of utilization reviews. Okay, there is the prospective review, the concurrent review, utilization review, and then the retrospective utilization review. So what is prospective utilization review? Right,